Welcome to video 2 of this Medicines and Older Māori course. In this video, we look at the ethnic variation and quality use of medicines in older adults in Aotearoa. I'm Jo Hikaka, a pharmacist at Waitemata DHB, and the information we'll be discussing comes from my research as a PhD candidate. Medicines are one of the most common tools we use in Western medicine for treating and preventing chronic and acute conditions. But medicines can also cause harm. As people get older, they are more likely to have a higher number of conditions which can benefit from treatment with medicines. But the flip side is they are also at increased risk of medicine-related harm. This can be because of age-related changes in the way medicines affect the body and how the body processes these medicines. Increasing number of medicines prescribed for different comorbidities, an increased number of prescribers who are involved in care, and increased complexity of medicine regimens. Individual medicines review is an important part of ensuring best use of medicines for particular people. However, if we are assessing quality at a population level, then we often have to use different measures. These may include the incidence or prevalence of a particular medicine in a general population. It may be looking at the proportion of people with a medical condition that are prescribed certain classes of medicines, or we can look at the level of drug-related harm. We can also use tools to assess the appropriate use of medicines, such as Beers criteria and the stop-start criteria. These tools, which are developed internationally for use in those 65 years and older, can be used as screening tools to identify whether a medicine is likely to be appropriate or not. They require you to know information about people's medical history, the medicines they are taking. For example, in someone who is above the age of 65 years and has a history of heart failure, the use of non-steroidal anti-inflammatory drugs such as diclofenac and Voltaren is likely to be inappropriate. We know that older adults are at higher risk of inappropriate prescribing, and we wanted to investigate if this was higher for certain older adult populations. We looked at New Zealand studies which investigated these quality measures to assess whether there was variation in access to quality medicines between Māori and non-Māori in Aotearoa. We know that in the general population, non-Māori have better access than Māori to medicines used to prevent cardiovascular disease, and this was replicated in our findings. This was found at a population level and also when disease burden was taken into account. Polypharmacy is often defined as the use of 5 or more regular medicines. In older adults, the more medicines you are on, the higher risk of adverse outcomes. Māori are more likely to experience polypharmacy at a younger age, largely due to earlier onset of chronic comorbidity, which is in turn influenced by reduced access to the social determinants of health, such as good quality housing, education, and employment opportunities. So, Māori are at more risk of harm from polypharmacy at an earlier age. Our research also suggested that older Māori were less likely to have access to newer therapies to treat things such as osteoporosis and prevent thromboembolism in the context of atrial fibrillation. When we are introducing new therapies, we need to be thinking about how we can do so in a way that is pro-equity and in a way that reduces access barriers that already exist. This is of course relevant when we are looking at the newer classes of medicines for the treatment of diabetes. When there are higher levels of inappropriate prescribing for Māori, it is more likely to be associated with a worse clinical outcome. When we look at levels of inappropriate prescribing, Māori are less likely to be prescribed medicines inappropriately according to these internationally validated criteria, such as stop-start. However, in those that are prescribed medicines inappropriately, Māori are more likely to have worse clinical outcomes, so more likely to be hospitalised and have higher mortality rates. For example, in those who don't receive anticoagulant treatment despite a history of AF, Māori are more likely than non-Māori to have a stroke. Of course, we can't say medicines access is the only cause of this increased risk. Institutional racism is a feature of the New Zealand health system, and there are a number of other factors likely to be contributing to these outcomes, such as reduced access to primary care, reduced access to specialist services. However, access to appropriate medicines is also an important component. To understand if medicines are being prescribed appropriately or not, population-level analysis gives us some information about trends. However, in this discussion, we haven't looked at economic considerations or how patient preference is incorporated into quality medicines use. To better understand realities at a patient level, we really need to be thinking about individual medicines reviews, and they have several benefits. These will be the topic of our next video, the third in this course. An independent reflection document and other relevant documents, tools, and links are available to you in this course. Feel free to start exploring them now, or you can continue watching the other videos in this course.